Welcome to today's COVID Echo. Today is September 9th, 2022. Today we have a full agenda. We will be discussing the updates to the Nashville area, as well as the COVID-19 vaccine and boosters. We have Imani Ransby and Anna Garrett presenting those presentations today. We can go ahead and get started with some housekeeping tips, Emily.
Yes, we are offering continuing medical and or nursing education credits, and I will put that link right in there. You do have to attend the full session today and then complete the evaluation that I just posted. And please go ahead and introduce yourselves in the chat. And yeah, this will be this is being recorded. You're being recorded. This will be available on our YouTube channel, and will also be shared by email within the week. And that is all I have to share.
Thank you, Emily. We will go ahead and get started with Imani Ransby. If you will share your screen.
Trying to figure out how I can hide the notes section.
You click on the little ellipses, the three dots,
Mm-hmm.
and it'll say hide presenter view.
Oh. Okay. Okay, I think we're good.
Yes.
Alrighty. Thank you, Brian. Hi, everyone. Welcome and thank you for joining today's USET COVID-19 Echo session. I hope you all have had a productive week as we transition into the weekend here. Today, I will be providing an update on COVID-19 epidemiology, specifically for the Nashville Service Area or USET region, as Brian mentioned. And this will just include going over some of the information that's featured in our USET aggregate surveillance and vaccination reports, which are issued every first Wednesday of the month. So we did send those out this past Wednesday. As a reminder, tribal representatives such as leadership and health directors are sent these USET aggregate reports alongside a tribal specific report, and that is on a monthly basis at this time. It is our hope that these surveillance and vaccination reports have continued to be helpful in supporting your COVID-19 response activities and preventing the spread of disease thus far. That being said, if you have any questions or concerns regarding the reports, please do feel free to contact the Tribal Epidemiology Center, and we are happy to assist. We really just want to ensure that the information we are providing is useful. And so if there are elements of the reports that you feel would be better tailored to meet the needs of your tribal nation, please feel free to let us know. So this next slide, I don't want to spend too much time on. These are just the data sources that we are pulling from to generate the graphs and figures that are featured in the reports. I do want to note that in the emails we send, there are a couple of supporting documents that are embedded in the links in the emails, including wastewater surveillance and then more about COVID-19 community levels and hospitalizations. So you can also take a look at those if you are interested. They are available. But to just summarize this slide, we are using a combination of COVID-19 related data, including CDC, HHS Protect, as well as information from the Indian Health Service Nashville area office. So if you were to start at the top of the USET aggregate report, you will first see this banner. It has information regarding the current variant or variants of concern, And at this time, that is still Omicron and mainly the BA.4 and BA.5 lineages. Below that, you will see the number of patients hospitalized with COVID-19 and purchased in referred care delivery areas, and then the 13 USET states combined. So those numbers as of this past week were 2,408 for the PERCTA areas, and then 9,586 for the USET states. And we have been focusing more on hospitalizations specifically rather than just transmission. We know that vaccinations have been very helpful in preventing people from getting hospitalized or dying from the virus, but at the same time, people have still been getting infected. So we do think that looking at hospitalizations is a good indicator and also helps public health professionals monitor whether or not hospitals are being exhausted due to SARS-CoV-2. And so underneath those two data points, we also have some information obtained from IHS. They send us a tracking sheet weekly with these numbers, the total number of positive COVID-19 test results at reporting facilities in the IHS Nashville area in the last week, as well as a 7-day positivity rate. So we've also been tracking this information too. And so this past week, the total number of positives was at 176, while the 7-day positivity rate was at 16.4%. And so both of those numbers did go down when compared to when we had our last echo session, which was on the 19th of August. And so at that time, we were at 182 positives, and then at 22.2% for the 7-day positivity rate. So just from that and comparing, you can see that we have come down, and there has been a decrease in cases since that time or since last month. And I do hope that we can continue on this downtrend, as a lot of areas have been experiencing a lot of cases over this past summer. So on this slide, we have displayed the COVID-19 community levels and USET states specifically. On the left, you have a map for that. And then on the right, I have listed the recommended prevention steps for each level, low, medium, and high. Unfortunately, CDC only updates this on a weekly basis. So this map is reflective of September 1st data. And for those that are not familiar with the community levels, they use a total of 3 indicators to calculate the community level for a specific state and or county. And those indicators include the new COVID-19 cases, new COVID-19 hospitalizations, and then the percentage of inpatient beds occupied by COVID-19 patients. Looking more closely at the map, you can see that in the USET region, some states are still at a high community level, including some of Texas, Louisiana, Alabama, Florida, South Carolina, and North Carolina. Whereas up north, New York and Maine, I'm not seeing as much of the high community level up there. As a reminder, if you are in an area with a high community level, it is recommended to wear a mask in indoor settings, and at all levels, if you can get vaccinated and boosted, then to definitely do so if you can. So moving on to this next map, we have wastewater has been another data source that we've been using to monitor COVID-19 in the Nashville area. This map was derived from CDC data, and it shows you the percentage of wastewater samples with SARS-CoV-2 as of 9/6/2022. And so we have the entire United States listed here. It's a gradient. So if the states that are that grayish, light gray color don't have as high of a percentage of wastewater samples with detectable virus, whereas the darker it gets, the more wastewater samples are detecting SARS-CoV-2. And if I'm not mistaken, these gray ones, they might also not be reporting at this time. If anyone is familiar with this map at all, the last one that we reported had a lot of grayed out areas. And so we are seeing that a lot of sites are signing on now to report wastewater data, which is excellent. But I do want to stress that when referencing wastewater surveillance, you really want to also couple that with other data such as hospitalizations and cases so that you ensure you're looking at the full picture of what is actually going on in your area. So these next two slides focus on COVID-19 hospital admissions and hospital bed utilization. So on the current slide, this information was again derived from CDC community levels data, and we have COVID-19 hospital admissions per 10,000 as of the first, with the USET PERCTA, USET states, and United States featured in this bar graph here. So for this past reporting period, we saw that for the USET purchase and referred care delivery areas, we were at about 215 cases per 10,000, while the USET states was at 1,034 cases per 10,000, and then the United States at 3,494 cases per 10,000. And all three of these data points have decreased from the previous month. If you were to reference what we provided last month, you'll see, in particular, our last echo session, we were at 232 for the USET PERCTA, 1,216 for the USET states, and then 4,125 for the United States. So we have seen some decreases in all three of those data points, which is great. But time will also tell. And so then I wanted to also go over this last slide before transitioning to vaccinations. Here we have listed the percentage of total inpatient hospital beds used as of the 6th of this month. And this information in particular is obtained from HHS Protect. And we have the USET PERCTA again here, USET states and the United States, except on a line graph now displaying this information over the past 3 months. So you can kind of track things over time. I really wanted to just pay attention more so to the August to September timeline. As you'll see, we've seen a slight decrease in both the USET PERCTA and USET states, where the inpatient hospital bed utilization was pretty much around 80%, a little under that. So slight decrease there, whereas, oh, my apologies, I'm referring to the USET PERCTA and the United States, whereas the USET states has increased a little bit there from 60 to around 70% for inpatient bed utilization. Moving on to these last few slides before I do hand it off, we have some vaccination data that's also featured in the reports. Again, just reiterating the importance of COVID-19 vaccines. We know that they have been an extremely valuable tool, and now we have available the updated or bivalent vaccine, which is excellent. And Anna will be covering that a little bit later. But on this slide in particular, we do have a bar graph which breaks out the reporting facilities in the IHS national area, the United States, as well as IHS. And we're looking at the percentage of population fully vaccinated. The first bar that is in gold for reporting facilities in the IHS national area, that is obtained from IHS directly, whereas the gray bars are obtained from CDC data. So I do just want to mention that. We are still making progress with getting people vaccinated, although maybe not as much as what we were seeing when when vaccinations were first available to us. So about 0.1% increases for each of those data points, as you can see from the previous month. Moving on to this next slide, we again have the percentage of population fully vaccinated, except here we have all of the USET states listed out as well, so you can look at that information. As we just mentioned, for reporting facilities in the IHS Nashville area, we were at 53.4% for the percentage of population fully vaccinated. And again, like what we saw on the last slide, we're seeing about 0.1 increases, very small increases here since the last month. And then this last slide on vaccinations, you notice it looks similar to the other bar graph, except now we are looking at the percentage of population fully vaccinated that have received another dose of COVID-19 vaccine. For this, we'll see that we did have quite an increase from 19.1% to 19.5% for reporting facilities in the IHS Nashville area. Whereas for all of the other USET states listed out, we're seeing, again, about 0.1 increases from the previous month. So I'm very interested to see what these numbers are going to be looking like as vaccinations ramp up again with the new bivalent vaccine. Here I just have listed some resources from CDC, some of the information, again, that we've included in the reports to support that. And then I will take any questions at this time.
Great presentation, Amani. Do we have any questions for Amani at this time? Hearing none, we can go ahead and move on to Anna's presentation on the vaccine and booster.
All right, perfect. Let me go ahead and share my screen. Can you guys see that okay? Okay, perfect. All right, so as we have all been waiting for, the bivalent COVID-19 booster vaccines are here, yay. So the bivalent booster vaccines, it does include two different components of the mRNA. So about half of it is the original strain, so that's the monovalent vaccine that we've kind of all been used to. And then the other half is specifically targeting the BA.4 and then BA.5 lineage of the Omicron variant. So why? As most of you guys are aware, the majority of recent cases have been of the Omicron lineage, so the BA.4 and then BA.5. Like we have previously discussed, that's just because of a mutation in the spike protein. It makes that lineage a little bit more infectious and less susceptible to that original vaccine strain. And this is predicted to continue circulating through fall and winter, which is why FDA and CDC wanted to get this booster vaccine out before then. And I do just want to note that this is only for use after the completed primary series of the monovalent. So this will only be for people who already have completed that primary series. We won't be using bivalent vaccines as of right now for like a first vaccine for anyone. So on August 31st, FDA went ahead and authorized their emergency use. And then on September 1st, CDC did endorse this recommendation. And CDC has been continuously updating their website to reflect this. So some key points. So the Pfizer-BioNTech single-dose bivalent COVID-19 booster vaccine was authorized for ages 12 and older. And then Moderna single-dose bivalent COVID-19 booster dose was authorized for ages 18 and older. And they are planning on authorizing these and looking at the safety data and all of that in the future for those younger than 12. But as of right now, this is what we're working with. And as well, the monovalent mRNA COVID vaccine booster dose is no longer authorized for ages 12 and older. So we're switching completely to this bivalent COVID booster dose for everyone 12 and older. So just some graphics to show kind of what's going on, because they're trying to simplify it, but it is a little bit confusing when you're first hearing about it. So there's not going to be any changes for children under 11. So the 6 months through 4 years, Moderna and Pfizer is still the same. And then 5 through 11 years is still the same. And then you'll see they do have this monovalent booster dose. So the monovalent booster dose that we have been used to, that's still going to be for those 11 and younger. So here by this little purple star is the new bivalent booster dose. So everyone 12 and older now will be switching to this bivalent booster dose after they've had their primary series. And their primary series can be Moderna, Novavax, or Pfizer. For timing, Novavax and Pfizer, we're just going to do the primary dose like we have done, wait 3 to 8 weeks, get their second dose, and then after they've completed that primary series, and then they can get the bivalent booster dose anytime at least 2 months after they've completed their primary series. For Moderna, same thing. We're doing the primary dose, waiting 4 to 8 weeks, finishing up that primary series, and then 2 months after that, they can go ahead and get their bivalent booster dose. For Johnson & Johnson, if they were to be eligible for that, just their primary dose, waiting 2 months, and then they can get their booster dose. And this is for people who are not moderately or severely immunocompromised. For those who are moderately or severely immunocompromised, you'll notice that this has not changed. This is for those 11 and younger. So like you see here, we're still utilizing that monovalent booster dose. And then for those who are moderately or severely immunocompromised, for those 12 and older, we have switched over to this bivalent booster dose. We're not necessarily counting the number of booster doses. We're just saying it can be at least 2 months after, the primary series or the last booster dose. So this is just a good kind of graphic showing what's going on. There are some just differences in timing between Moderna, Pfizer, and Novavax for that primary series. And then Evishield, we will talk about that in just a minute. So since we have this new product, there are going to be some new labels as well. So likely in your stock, you're going to have the monovalent product as well as the bivalent product. So it's just very important that you make sure kind of and double check what you're grabbing for who and where they are in that vaccine series. So just the differences in labels, what these are going to look like. Again, this is only affecting those 12 years and older. So this would be the Pfizer label. This one on the right here is the new bivalent label. For Moderna as well, you have the monovalent and then the bivalent product. So again, just important to make sure of what you're grabbing when you're getting vaccines. And then this on the right here is that new bivalent label for Moderna. And again, that's ages 18 and older. You'll see here on the left, this Moderna is still going to be used as the booster dose for those 11 and younger. So we'll just want to be careful when it says booster doses only on this one, that's only for those 11 and younger. And we're going to be doing the bivalent one for those 18 and older if we are using Moderna for that. So just kind of being very careful on what label it says, what you're using for who. So now what is up to date? So per the CDC, you are up to date with your COVID-19 vaccines if you have completed a COVID-19 vaccine primary series and you have received the most recent booster dose recommended for you by the CDC. So obviously these recommendations are based on a lot of different factors, your age, which vaccine you first received for your primary series, and then the time since your last dose or since you last had a COVID-19 infection or tested positive. So obviously those who are moderately or severely immunocompromised are going to have some different recommendations for the COVID vaccines than those who are not. So like I said, this is meant to simplify So regardless of your primary series, whichever brand that might have been, and then whatever number of booster doses you've gotten since this point, as long as you're waiting at least 2 months after that last booster dose or that last primary series, you're now eligible for the bivalent booster dose. The plan right now is that they're thinking this is going to be a once a year kind of booster dose, kind of like how we do seasonal flu, but this is kind of what we have right now. So it doesn't really matter now what your primary series was, as long as you have it, and then how many other boosters you've gotten. Everyone now is eligible for this bivalent booster dose as long as you're 12 years and up. So timing considerations, like I've mentioned, it's going to be 2 months after your primary series. Another thing to take into consideration is if you have either a current or a past SARS-CoV-2 infection. So you can wait and talk to your healthcare provider, or if you are a healthcare provider, consider recommending waiting just based on the individual patient about 3 months after the symptom onset, or if they had a positive test, just since they'll likely have that kind of natural immunity from the infection and then boosting after that with the new bivalent booster. At minimum, though, you're going to want to make sure there's no symptoms. So making sure, they are recovered from that illness and there's no more isolation protocols in place. That's the minimum that you can do that bivalent booster now. And then just taking into consideration individual risk factors, and the timing is really important. But just main points is at least 2 months after the primary series. For Evishield, if you do have any patients on this, that's the monoclonal antibodies. So like you're probably aware, you can do any, COVID vaccine dose, primary or booster. You can do, wait at least 2 weeks, go ahead and do that Evishield dose every 6 months. There's no minimum interval from doing the Evishield to getting your COVID vaccine or booster dose. So just taking into consideration that kind of timing. So for product mixing, the primary series, as you're aware, you don't want to be mixing products. You're going to either stick with Pfizer for 1 and 2, Moderna 1 and 2, or Novavax. So you don't want to switch between those. So for the booster doses, though, so it does kind of vary by age, like I was saying. So anyone ages 18 and up, you can get a different product for your booster, either Pfizer or Moderna. So it could be different as your primary series. Ages 12 through 17, you can get a different product for your booster. That's going to be Pfizer. And then ages 5 to 11, you should do the Pfizer primary series and then get the Pfizer booster. But like I was mentioning, they're not going to be eligible for that bivalent booster just yet. And then ages 12 and up, you can get the bivalent Pfizer booster, or so you can do the bivalent Pfizer booster and match that with the Moderna primary series. This age group is no longer eligible for that monovalent booster. And then as of right now, Novavax is not authorized as a booster dose, just the primary series. So I hope that made sense. So for co-administration of vaccines, and I know this has been kind of a topic recently, trying to increase, back to school vaccinations, flu vaccines. So as of right now, providers should be offering all vaccines for which a person is eligible at the same time, obviously following, correct administration of multiple vaccines at once. Just making sure you're doing, the age-appropriate doses for vaccines simultaneously, and just making sure there's no, contraindications for anything like that. So for example, right now would be a good time to be offering the seasonal influenza and the bivalent COVID booster dose, if that is applicable to your patients and their ages. I do want to note monkeypox has been in the news recently, and there has been a push to go ahead and do some vaccination pre and prophylaxis for that. There have been some recommendations that adolescent or young males may consider waiting 4 weeks after they get their Jynneos or ACAM 2000, which are the monkeypox or the orthopox virus vaccines, before receiving their COVID-19 vaccines. That's just due to the increased risk factors of myocarditis in that age group, as well as the unknown risks of the Jynneos and ACAM 2000 for myocarditis. So just kind of a precaution there. But on the opposite side, anyone should not be delaying getting their prophylaxis for monkeypox due to a recent COVID-19 vaccine. And there is no minimum interval between these vaccines that is mandated or necessary. I did just want to bring that up since I know there have been some recent vaccination campaigns surrounding these. For VAERS, the Vaccine Adverse Event Reporting System, I anticipate there might be some errors in vaccine administration just due to the sudden switch and a whole new vaccine, and now we're not doing the monovalent booster doses for those age 12 and up. So just making sure if you do accidentally give the wrong product or the wrong dose to someone in the incorrect age group or anything like that, just making sure you're reporting that if it is applicable. I do want to highlight these upcoming calls about this. So on the left here, this coming Tuesday at 2 to 3 Eastern time, there is a partner call, just kind of going more in depth on the new guidance. And then on the right here, National Indian Health Board on September 14th at 4 o'clock Eastern time. Again, there's just more about the Omicron response. And then I will mention the health and safety data. There's like 130 slide presentation linked here if you are interested in looking at anything specific. It is mirroring what we have seen for the other COVID-19 vaccines. There wasn't anything too different in that. So if you do have any questions about that, I would refer you to this, but I can also take some questions on that as well. And then these are all linked. And like I did say, CDC is kind of continually updating all of their documents to reflect this new change. There's some really good information on the clinical considerations for the bivalent boosters, just offering some more specific kind of clinical guidance. And then I can take any questions if you have any.
It was very informative. Thank you, Anna. Do we have any questions for Anna at this time?
I don't have a question. I just wanted to say I put a plug in the chat for a resource where you can find areas or places that will have the bivalent vaccine available.
Yes, they did start shipping those earlier this week, so hopefully they'll be widely available soon here.
Thank you. Emily spoke. She wrote in the chat, recently heard about the nasal sprays vaccine. Is that coming to the United States? Do you have any idea?
I do not know as of now. Anna, do you know any information about that or have any information about that?
I haven't heard anything about that. I haven't heard anything about that. I believe the next thing on their priority list is doing the bivalent boosters for the younger age group, but we will wait and see.
Congratulations, Sean, on getting your booster. I need to get mine too. I guess we all have to get them, right?
Yeah. I know in my area, I live in South Florida. I'm with the Seminole Tribe of Florida here in Fort Lauderdale area, and they already have the bivalent. They announced it. I got it at a CVS. So it's been shipped out. I don't know where everybody else lives, but down here they have it free and easy. I booked my appointment like a day ago, yesterday, and received an appointment today and just went into CVS. I was an hour late because I had another Zoom I was on, but they accepted me. It's not like the first booster or the first vaccination where it was like trying to find 3 weeks out dates. So the dates are readily available down here.
How was the shot for you?
Just like the other two, just quick and easy. But of course, the nurse or the pharmacist that gives the shot, she basically, the guy next to me was asking a bunch of questions and she explained everybody reacts differently. I know my booster that I received, now I see it, it's almost a year. It was October of last year that I received my booster. And it just made me a little lazy, a little, but she said, listen, she's had some more severe reactions to the shot. And she said, you just can't tell. It depends on if you've had a booster or had the original shot, you're going to have basically the same. You should have the same side effects. So far, nothing. But let's see until later.
Well, good luck.
Thanks.
Do we have any other comments or questions? And with that, we can go ahead and conclude today's ECHO. And remember to fill out the evaluation. Thank you, Emily, to give us some helpful feedback. And thank you all. Y'all have a great day.